Here's our roadmap for today. 1. Congenital anomalies and dysfunctions. 2. Acute pancreatitis, or the explosion. 3. Diagnosing and scoring severity. 4. Managing pancreatitis and its complications. And finally, 5. The burnout of chronic pancreatitis.
Section 1. Congenital anomalies and dysfunctions. Basically, when embryology goes wrong. Before a patient ever takes their first drink or develops a single gallstone, they can actually be set up for failure by their own embryology. The absolutely crucial thing here is distinguishing between the two major congenital defects, pancreas divisum and annular pancreas. Now, pancreas divisum is the most common congenital anomaly we see in the pancreas. It happens when the dorsal and ventral pancreatic buds simply fail to fuse. Because the main duct is then forced to handle a massive volume of secretions it literally wasn't built for, these patients are super predisposed to acute pancreatitis. On the flip side, we've got annular pancreas. This is a malrotation issue. The ventral bud physically wraps around and literally strangles the second part of the duodenum. And because of exactly where this blockage occurs, it causes severe, non-bilious vomiting in infants. If you look at the imaging, you're going to see that classic double bubble sign.
The Milwaukee classification for sphincter of Oddi dysfunction perfectly highlights what happens when the main drainage point is compromised. This is a major functional issue. When the sphincter guarding the pancreas dysfunctions, it can trigger some pretty severe biliary or pancreatic pain. Look closely at type 1 patients. They have the complete triad: pain, dilated ducts, and raised enzymes. Because we have definitive, rock-solid proof of a physical blockage, these type 1 patients are hands down the best candidates for surgical intervention, like an ERCP with a sphincterotomy, to just cut the sphincter and relieve all that built-up pressure.
Moving right along to Section 2, acute pancreatitis, the explosion, sudden and severe inflammation. Listen, when the pancreas gets angry, it doesn't just swell up. It fundamentally turns on itself. So what causes this explosion? Well, while alcohol definitely gets the blame a lot, gallstones are actually the true #1 cause of acute pancreatic inflammation overall. Alcohol is sitting firmly in second place. Now, if we're talking about kids, the most common cause is actually blunt trauma to the abdomen. Think of a kid falling forward hard onto their bicycle handlebars. We also, unfortunately, have to look in the mirror here because ERCP procedures, the exact same procedures we use to treat biliary issues, are the most common iatrogenic or doctor-caused trigger. And finally, keep in mind that various drugs like antiretrovirals and thiazide diuretics can also trigger the whole shebang.
So what's actually happening under the hood? Why does it just explode? It all comes down to the colocalization theory. Normally, the pancreas makes these inactive digestive enzymes that are perfectly safe until they reach the gut. But in acute pancreatitis, some trigger makes the zymogen granules and lysosomes inside the pancreas fuse way too early. This unleashes active trypsin directly into the pancreatic tissue itself. It's wild. The organ basically starts to digest itself from the inside out, which kicks off massive acinar cell death and this intense, cascading systemic inflammation.
Picture this. A patient rolls into the ER with that classic agonizing epigastric pain that shoots straight through to their back. We need to confirm the diagnosis fast, right? So we draw blood for both amylase and lipase. Now, amylase spikes fast, but it drops off just as quickly. And frankly, it's notoriously unspecific. It could shoot up from a perforated ulcer or even gut ischemia. So scratch amylase. Lipase is really your best friend here. It stays elevated much longer, giving you a significantly wider diagnostic window, and it's highly, highly specific to the pancreas. Also, pro tip, if their liver enzymes are elevated too, that's your giant flashing clue that a gallstone is the culprit.
All right, Section 3, diagnosing and scoring severity. We've got to quantify the damage. To actually get a handle on this condition, we first need to measure exactly how bad this internal explosion is. And the magic number here? 72. 72 hours. This is absolutely critical, guys. A contrast-enhanced CT scan is the absolute best imaging modality we have for acute pancreatitis, but, and this is a big but, you must wait 72 hours after symptom onset before doing it. If you rush and scan them on day 1, the tissue just hasn't fully declared itself dead or alive yet. You run a massive risk of underestimating the true extent of the pancreatic necrosis. You have to wait those 72 hours to see the real battlefield. But what do we do while we wait for that scan? We use clinical scoring systems. Ranson's criteria is a bit dense, but it's absolutely vital. Notice how it's completely split into 2 phases: parameters we measure right at admission, and then parameters we check 48 hours later. We're looking at things like age, white blood cell count, glucose. And then later, we're watching for drops in hematocrit or dangerous fluid sequestration.
If you hit a score of 3 or more, that indicates severe pancreatitis with a much, much higher risk of mortality. It's a major red flag. Now, Renson's is classic for sure, but once you finally get that 72-hour scan, the CT Severity Index, also known as the Balthazar score, is the undisputed gold standard for assessing acute severity. It beautifully combines the physical inflammation you actually see on the scan with the percentage of dead necrotic tissue. Anything over a 6 means severe disease. We do have some other heavily utilized scores out there, like APACH-2, where a score over 8 is severe, and also some simpler alternatives like BISAP if you need a quick bedside tool.
Okay, Section 4, Managing Pancreatitis and its Complications. Time to control the burn.
Let's get into the nitty-gritty of how we actually treat these folks and manage the incredibly dangerous complications of an organ actively autodigesting. Our core management protocols have totally evolved over the years. Right out of the gate, we start with bowel rest and aggressive IV fluids. Ringer's lactate is definitely preferred here. For pain, don't be shy. Hit them with heavy analgesics. Modern consensus tells us opioids are perfectly safe to use in this scenario. But here's the catch with food and drugs. The protocol is super strict. You absolutely must start enteral feeding, so tube feeding directly into the gut, as early as possible. This is a game changer because it keeps the gut lining healthy and totally stops dangerous gut bacteria from translocating into the bloodstream. Also, hear me on this. There is zero role for routine prophylactic antibiotics. None. You only break out the heavy hitters like meropenem if you have definitive proof of infected tissue necrosis. And lastly, if a gallstone started this whole mess, you've got to take out that gallbladder before they get discharged. Otherwise, you're risking a lethal second attack. So what if that 72-hour CT scan does show pockets of dead tissue and suddenly your patient spikes a fever with the sky-high white count? Boom, you're dealing with infected necrosis. You cannot just rush them to the OR and cut them wide open. You have to strictly follow the step-up approach. Start with the absolute least invasive method, percutaneous drainage using a pigtail catheter. If they're still not getting better, then you step it up to a minimally invasive retroperitoneal debridement. Going in for an open surgery and open necrosectomy is strictly a last resort because, frankly, it carries a devastatingly high mortality rate. Now, as the patient starts to recover, you might see a localized complication pop up called a pseudocyst. It's called a pseudo or false cyst because it doesn't actually have a true epithelial lining. It's basically just a pocket walled off by inflammatory granulation tissue. These guys love to form right behind the stomach in a space we call the lesser sac. And because they're sitting right there, they physically push the stomach up, which leaves the patient dealing with constant nausea and vomiting. But hey, the good news? Roughly 70% of these will just go away completely on their own. We only jump in with surgery if they grow bigger than 6 centimeters or hang around for more than 6 weeks.
Which brings us to our final act, Section 5, the burnout. Chronic pancreatitis and irreversible parenchymal damage.
This is the endgame of repeated acute attacks. The organ is left permanently scarred, totally fibrotic, and just unable to do its job. We use the acronym TGAR-O to remember the causes of this chronic phase. And notice the massive shift here. In the acute phase, gallstones were the biggest culprit, but in chronic pancreatitis, long-term chronic alcohol abuse is the undisputed #1 cause. We also start seeing a massive role for genetic mutations here. Keep your eyes peeled for mutations like PRSS1 or the SPINK1 gene, which is famously linked to tropical calcific pancreatitis from eating cassava. Basically, these toxins and genetic hiccups subject the pancreas to this relentless, low-grade, everyday destruction.
You know, the pancreas is a really resilient organ, which in this case is actually kind of a curse. A mind-blowing 90% of the pancreatic tissue has to be completely physically destroyed by fibrosis before the patient even starts showing clinical signs of exocrine or endocrine insufficiency. It's crazy. By the time the patient even realizes something is wrong, almost the entire organ is already gone.
And that leads us to a truly fascinating yet tragic clinical paradox that we call the burned out pancreas. Early on in chronic pancreatitis, the pain is just agonizing. But over the years, as the physical destruction of the gland gets worse and worse, the patient's abdominal pain actually starts to decrease. They think they're feeling better, but the reality, the acinar cells that produce those pain signals are just completely dead. The organ has quite literally burned itself out.
When we finally get an MRCP scan on one of these burned out organs, we see this super classic radiological sign, the chain of lakes. What happens is the chronic inflammation causes these calcium carbonate stones to form, which then create really tight strictures followed by bulging dilations all along the main duct. It beautifully and sadly illustrates the internal scarring. The imaging literally looks exactly like a string of tiny lakes trapped inside a heavily fibrotic duct.
Now, if those blockages cause the main duct to dilate to more than 5 millimeters, the pressure builds up and causes intractable, awful pain. We have to go in and relieve it surgically. This is where drainage procedures come in. We can opt for Duval's procedure, which is basically an end-to-end connection between the pancreas and the jejunum. Or, if we need a much more comprehensive fix, we use Puestau's procedure. This is wild. The surgeon literally slices open the entire longitudinal length of the pancreatic duct and attaches it side to side to the bowel. It essentially allows that entire chain of lakes to just drain freely. At the end of the day, medical management for chronic pancreatitis is all about a triad: replacing what the body lost. For the exocrine insufficiency, where the patient literally can't absorb their food, we hit them with massive daily doses of synthetic enzymes. We're talking around 90,000 international units, always paired with a PPI. For the endocrine insufficiency, which essentially manifests as diabetes, we prescribe insulin. And for the pain, we aggressively manage it with analgesics or, like we just saw, those targeted ductal drainage surgeries.
But here's the thing, treating the symptoms is really only half the battle. Because chronic pancreatitis, especially those genetically driven variants we talked about, heavily increases the risk of pancreatic cancer. Which leaves us with a really chilling question to ponder. When you have all this chronic inflammation and profound destruction, what silent, deadly conditions might be hiding right now in the ashes of a burned-out pancreas? Think about that. That's all for this explainer. Thanks for joining me, and keep questioning everything.